As we need to use the anticoagulants in acute myocardial infarction, we need to understand the coagulation cascade. As you can see, basically here, there should be activation of factor 10 to factor 10A. This is the most crucial step. Once there is factor 10A, this factor 10A along with factor 5, calcium and phospholipids acts on prothrombin or factor 2 and converts that into thrombin or factor 2A. This factor 2A acts on fibrinogen or factor 1 to convert it into fibrin, which is the stable mesh of the clot. So, activated factor 10 in the presence of factor 5, calcium and phospholipid converts prothrombin to thrombin, and this thrombin, which is factor 2A, acts on fibrinogen and converts into an activated fibrin factor 1, which is fibrin. This fibrin is the mesh of the clot in which all the cellular elements, platelets, everything is entangled. Now, how does factor 10A come? Factor 10A, 10 is available in the body, in the blood, and this 10 has to be activated to 10A. That can occur through two pathways. One is called the extrinsic pathway, the other is called the intrinsic pathway. In the extrinsic pathway, when there is an injury to the tissues, tissue factor or factor 3 is released. Tissue factor and factor 3 are released. This tissue factor, when it is activated, that becomes factor 7A. This factor 7A along with tissue factor complex, the activated factor 7A and the tissue factor, when they combine with one another, and that becomes a complex, and that complex in the presence of calcium acts on factor 10 to convert that into factor 10A. So, this is the extrinsic pathway when there is an injury to the tissue, as happens in a case of when plaque rupture, in a case, vulnerable plaque rupture in a case of acute coronary syndrome. Intrinsic pathway is when there is a contact activation of factor 12A. Normally the blood vessels lining will not excite any contact activation. If the blood meets with any foreign substance or foreign area, then there will be contact activation and then factor 12A is formed. This factor 12A acts on HMWK and prekallikrenin, and which further activate this prekallikrenin becomes kallikrenin, kallikrenin activates factor 9 and factor 11. These activated factor 9 and factor 11 act on factor 9 and they form a complex with factor 8A. Factor 8A and factor 9A complex, which again can activate factor 10A to 10 to 10A, which is the intrinsic pathway. So, this differentiation is not much of interest for us. Only to note that there is what is called the tissue factor, and this tissue factor along with factor 3 and then the complex of tissue factor with factor 7A is essential in the presence of calcium to activate factor 10 to 10A, which processes the coagulation cascade further, and this is called the prothrombinase complex. Prothrombinase complex is prothrombin to thrombin, thrombin to fibrinogen, fibrinogen to fibrin. This is called the common pathway. So, your antithrombotic treatment either can block at that level or can block at this level. So, the antithrombotics we use, they may have an action on the factor 10 and prevent it from becoming factor 10A, or they can act on thrombin and then bind the thrombin so that this thrombin will not act on fibrinogen to convert into fibrin. Inhibition of factor 10A reducing the production of thrombin, inhibition of thrombin from activating the fibrinogen. These are the two mechanisms by which antithrombotic agents work. Some agents work more on factor 10A side, some on the thrombin side, which we will see in the subsequent slide. At the moment, we have got four important classes of drugs. One is the conventional unfractionated heparin, the red arrows. Then low molecular weight heparin, typically represented by enoxaparin in case of acute coronary syndromes. The other molecules, dalteparin, that they are not that active. The only important molecule here for is enoxaparin, the fondaparinux and the bivalirudin. Fondaparinux is represented by the blue and bivalirudin by the green. Look here, the antithrombin effect on these substances can be on factor 10A or on thrombin, which I have seen in the previous slide. So bivalirudin acts on the thrombin and prevents the thrombins acting on the fibrinogen to convert into fibrin. So it acts on the final pathway of the coagulation. Whereas conventional heparin, it is mostly active on the thrombin, partly active on the factor 10A inhibition. Whereas low molecular heparins, the reverse. They have maximum action on 10A and minimum action on the thrombin. Whereas fondaparinux has action directly on the 10A and no action on the thrombin. So this 10A is generated by two pathways we know, extrinsic and intrinsic. These agents, particularly the heparin, has got weak action on some of these areas of intrinsic pathway also. But the most important area is blockage of 10A and blocking the thrombin, antithrombin effects. So the bleeding complications will be more in situations where we have got stronger action on the thrombin as well as on 10A. If there is only a stronger action on 10A, the bleeding complications will be less. So much so here you see fondaparinux with its action on 10A is comparatively a safer drug when you compare to the other drugs. Low molecular weight heparins in acute coronary syndrome. The advantages of LMWH over conventional heparin or unfractionated heparin are better bioavailability, higher ratio of 3:1 of anti-10A to antithrombin activity, the more act on the 10A than on the thrombin, longer anti-10A activity, and then compared to the heparin, which is short-lived, you need to give recurring doses of every 6 hours or so. They avoid rebound coagulation, induces less platelet activation, ease of use, subcutaneous either once a day or twice a day, and need no monitoring of the prothrombin time or partial thromboplastin time. So these are the advantages. I told you that the most important drug to be used is enoxaparin. Out of the 4 classes of anticoagulants we have, which one do we choose? Unfractionated heparin, low molecular heparins, fondaparinux, bivalirudin. When there is severe CKD, we cannot use conventional heparin. We can use, but with caution. Whereas we cannot use low molecular heparins, fondaparinux, and of course with caution we can use bivalirudin. When there is an increased risk of bleeding, this is neutral, this is selective, these two are very good in the presence of increased risk of bleeding. When there is thrombocytopenia is worst, that is heparin induced thrombocytopenia with unfractionated heparin, better with low molecular weight, better with fondaparinux, and the best, there is no thrombocytopenia almost, with bivalirudin. Early invasive treatment, when we want to use, early invasive means early PCI we want to do, unfractionated heparin, low molecular heparins are very good, particularly enoxaparin, fondaparinux is not advisable, and bivalirudin is very good. In fact, bivalirudin, when we use bivalirudin, it is convenient for us. We can even drop the GP2A, 2B3A blockers. So we have 3 types of agents, antithrombotic agents, which are antiplatelets, anticoagulants, and fibrinolytics. Low risk patients, when we choose conservative treatment in case of non-ST segment elevation myocardial infarction, there are a conservative strategy and the early invasive strategy. When we choose the conservative strategy in NST-AMI, then of course aspirin and clopidogrel in combination have to be used. Anticoagulants of choice can be unfractionated heparin or enoxaparin, LMWH or fondaparinux or bivalirudine. No fibrinolytics, please. Whenever we have non-ST segment elevation myocardial infarction, we should not use fibrinolytics because they do more harm than good. In high-risk patients of NSTMI, where we select invasive treatment and do a PCI and then coronary angiogram followed by percutaneous intervention, aspirin clopidogrel combination and then the GP blockers have to be used. Triple platelet. Here we have double platelet and we have triple platelets. Of course, the anticoagulants of choice, unfractionated heparin or low molecular heparin, not fondaparinux at all. We have to use these drugs or bivalirudine. Of course, in NSTMI, we should not use fibrinolytic agents. When there is STEMI, when PCI is not available, when we are not going to do PCI in a patient of STEMI, aspirin clopidogrel, unfractionated heparin, low molecular heparin or fondaparinux can be used, and the fibrinolytics of choice would be either TNK tenecteplase or RTPA or TPA. What are these? We will see in the subsequent slides. What are the fibrinolytic agents of choice? We will see in our subsequent slides. What are the thrombotic agents, antithrombotic agents in PCI? When we select PCI, of course, we don't use fibrinolysis. That is why all the fibrinolytic agents are none. Whereas primary PCI, aspirin, clopidogrel plus minus GP blocker, hepciximab. Anticoagulation, unfractionated heparin or bivalirudine. When there is an elective PCI in a low risk patient, aspirin, clopidogrel, unfractionated heparin or low molecular heparin and bivalirudine. Elective high risk patient, aspirin, clopidogrel along with eptifibatide or hepciximab, one of the GP blockers, along with anticoagulation, unfractionated or low molecular weight or bivalirudine. So much so, the anticoagulant of choice in a case of PCI is either unfractionated heparin or bivalirudine, not fondaparinux, not low molecular heparin, because the titration will be much easier because the half-life is smaller for this, and you can titrate and stop the anticoagulant whenever you want, and it can be easily reversed by protamine. And that is these are the two advantages. It is easily reversibility by protamine and the easy titration by reducing the dose or increasing the dose. That is why these two drugs, bivalirudine is a very safe drug. It can be used. Fondaparinux and low molecular heparin are not the anticoagulants of choice when we decide PCI, either primary or elective low risk or elective high risk. Of course, there is no role for fibrinolytic agents when we choose PCI.